The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome to the next episode of TMD Demystified. I am Tony Urbanek. Whether you be a dentist interested in learning how to actually treat TMD, or one of our current network providers who are now in, I believe, 18 or 19 states who are licensed to use the Urbanek device and protocol for the treatment, non-surgical treatment of TMD, or whether you are a current, past, or potential patient with the terrible symptoms of TMD, temporomandibular joint disorder, welcome. Glad you're here. I'm here to help you. That's my purpose. I'm here to help you understand this problem, this disease that is poorly understood, very poorly treated over the past 70 years. I've talked about it many, many times on previous episodes. Why that occurred, why it's continuing to occur, why half the dentists who are given the responsibility of treating this problem, either half the dentists put their fingers in their ears and hope that they don't have to see a TMD patient because they're the honest ones. They know they don't know anything about it, and more likely don't want to know anything about it because they know that the prior treatments and the history on this problem is terrible, or the 50% of dentists who make a nightguard and give it to the patient, knowing that it's not effective, but hope they don't come back. And then there's the TMD gurus who abuse the system and abuse what knowledge they have about this problem and use smoke and mirrors. Gurus. But today I'm going to just talk about why it took a surgeon, why it took a surgeon to figure this out, the non-surgical treatment of TMD. And looking back, it's easy to see it through the retrospective scope. As a looking back, it's just really obvious. For 36 years, part of my training, a very big part of my training, was the surgical treatment of temporomandibular joint disorders. And my mentor was Dr. David Hall, who was an icon who began the oral and maxillofacial surgery program at Vanderbilt way back in the early 70s, an icon in the field of oral and maxillofacial surgery. And one of his special areas of interest was temporomandibular joint disorder. And he tried to figure out a way and actually developed surgical techniques for the treatment of temporomandibular joint disorders. So coming in my training, starting in the early 70s and the mid 70s, I was well versed in the surgical treatment of temporomandibular joint disorder in all varieties, but especially in the work that he had done. And I won't give you the specifics of how he treated it. And it had some theoretical value. And now looking back retrospectively, what his surgical method was, without going into detail, was an attempt to surgically decrease the inflammation within the temporomandibular joint by unloading the joint, by separating the condyle and giving space between the condyle and the fossa, allowing, theoretically again, the inflammation within the joint to decrease. Although I don't think that he was thinking about inflammation. I think he was just trying to unload the joint by separating the condyle, the ball part of the ball and socket, apart. And those papers that he wrote, I think he wrote 3 separate papers on that surgical procedure. And I don't want to go into that because that surgical procedure had some value, but it had some other problems with it that created problems of its own. Again, I was well versed on it. My evaluation once I came out of training was that I didn't like that procedure. But in any case, over 36 years, I did over 2,000 surgical procedures on the temporomandibular joint, along with tremendous amount of work on cleft lip and cleft palate, orthognathic surgery, facial growth and development problems, nerve reconstruction of the face, cancer reconstruction, etc. And but 2,000 temporomandibular joint cases, and after 36 years, that is the first 36 of my 50-year career as a operating oral maxillofacial surgeon in private practice. Once I finished Vanderbilt, my training and degrees at Vanderbilt, I elected not to go into academics and elected to come into private practice. But for those first 36 years, I had a tremendous amount of experience in doing various types of temporomandibular joint surgery, half of them what we call open joint surgery through an incision in front of the ear where you get direct access, and whatever you're going to do to or with that joint, you have direct access to it, to rebuild it, to remove portions of it, whatever you're going to do. And then half of those cases were through a scope, an arthroscope, which is a well-described, well-utilized surgical procedure, but doing everything through a scope. And as I've spoken on before, after 36 years and 2,000 cases, I found that a full third of patients I operated on would be back within 6 months to 2 years, and they would have the exact same symptoms that they presented with originally. And after reviewing those case studies over a long weekend, I decided I was not going to do any more temporomandibular joint surgery because that response, I could not look at a patient in a consultation and say, I'm going to do blah, 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 certain kind of surgical procedure for you, knowing that a third of the time you'd be back within a year or two with the same symptoms. So if I felt better just not doing any more temporomandibular joint surgery because of my broad background, I decided to see if I could figure out, if I could discover what was really going on with temporomandibular joint issues, problems, because I knew that the surgeons didn't have the answer. And I knew that the dentists didn't have the answer. I was well aware early in my career that half the dentists put their fingers in their ear when they hear the word TMJ, and half make a night guard and hope the patient doesn't come back. And then there's all kind of nonsense that are developed and promoted by the gurus. Biggest, most current one is Botox, and I think I have an episode specifically on Botox, which is, frankly, works no better than saline, and proven by an academic study. Amazingly so, but still the doctors out there and the expanding utilization of Botox by dentists and other types of physicians for facial pain is amazing to me, because at very best, it's just a localized procedure that has to be repeated every 3 to 4 months, indefinitely, and that the pains move around, so you can be chasing facial pain with Botox forever to the tune of, and one of my patients to the tune of $200,000. Seriously. I had a patient who claimed, and she said, I'll bring you in the receipts. $200,000 on Botox because of unexplained, disparate facial pains. Amazing. But the topic is, how come it took a surgeon to figure this out? And looking back through the retrospectoscope, it became obvious exactly what happened. But there's three parts that actually had to come together to figure out why chronic inflammation drives all the symptoms, the disparate symptoms of temporomandibular joint disease. The disparate symptoms being a list of symptoms that do not seem related. The symptoms themselves on the surface, really in the minds of dentists and physicians and scientists and academicians, don't seem to be related. But yet we know that these symptoms are commonly seen associated with people who have jaw joint problems. And those symptoms, I will repeat again, are frequent and or recurring headache, earache. And when I say headache, I mean any kind of headache, but especially headaches that are confused with migraine headaches, as they say in the South. Headaches, earaches, neck pain, jaw pain, sometimes very often confused with dental pain. Many patients actually have teeth taken out because they claim in front of a dentist, my tooth hurts, and nothing wrong with the tooth, but they talk a dentist into taking out a few teeth. We've seen that often because they think that it's a toothache when actually the pain is generated via the temporomandibular joint. Upper back and shoulder pain and tightness, ringing in the ears, called tinnitus, subjective hearing loss, which is that feeling of fullness in the ears, like you're got your ear full of water and can't clear it. That's subjective hearing loss. Vertigo, dizziness, which are separate in distinction, but same concept. They're a little different in definition, just dizziness and vertigo. And arm, hand, finger tingling and numbness, the disparate symptom. It's if you know the anatomy, I explain how you can get arm, hand, finger tingling and numbness with inflammation in this joint. And then the last is various kinds of jaw locking, inability to open, either completely, partially, several times a day, different varieties of locking of the jaw joint. There are a few secondary ones, like one of the complaints is, which I won't try to explain to you right here, my teeth don't fit together evenly. That's a TMD complaint. And we are beginning to see and realize many patients. I had one yesterday in my clinic, my Monday clinic. I only see patients one day a week now. And my Monday clinic, a patient started to talk about her vision problems that were improved when the inflammation in the temporomandibular joint went away, dispersed, decreased. So why did it take a surgeon to figure this out? Well, the biggest reason is when I did those 2,000 cases, when I did 2,000 temporomandibular joint surgeries, it was standard operating procedure 100% of the time in any hospital I worked in to send a piece of tissue, piece of pathology tissue to the pathologist for review whenever I did one of those 2,000 cases. And it was always returned, whether it returned immediately if I was thinking of I needed an immediate response while I was in the operating room, or whether it was in 2 to 3 days when the written pathology report returned, that the first line of the pathology report always was chronic inflammation, whether it actually said chronic inflammation in quotes, or whether it was a description of the cell types that create or included with chronic inflammation. Chronic inflammation was always number one on the pathology report, no matter what else it said. And again, looking back on that, it was one of the primary basics on which I began to think about, well, what's really going on with this problem called TMD? Well, the common denominator for sure, whatever else other common denominators may be there, or whatever else is going on, if you have TMD, you have chronic inflammation within the temporomandibular joint. That was proven to me after 2,000 cases and 2,000 pathology reports, whether they be done open joint surgery or through an arthroscope. The second piece of data that needed to be understood and acknowledged that brought the actual resolution, non-surgical resolution of this problem into view was something that every dentist knows and learns in dental school. And that is the majority of load on this joint, load, pressure, utilization, 90% is via the posterior teeth. In other words, another way to say that is 90% of the loads on the temporomandibular joint come from the posterior teeth. That is why you crack nuts with your back teeth, not your front teeth, because the front teeth don't allow large loadings. You can't, the nociceptors, the proprioceptors that encompass or surround teeth, that's why you can't crack nuts with your front teeth. They don't allow that kind of pressure, but the back teeth do, and 90% of the loads are on the back teeth. And so that is something that every dentist knows, and of course physicians don't know, but being both a physician and a dentist, it took kind of both areas of general knowledge that brought the whole concept and solution into view. And the third and literally final piece of data that brought the solution and understanding into view was something that arrived to me during my rotation in orthopedic surgery, in my orthopedic rotation at Vanderbilt, with one of my orthopedic resident buddies who said, you need to learn about tennis elbow. And tennis elbow is nothing more than inflammation of the elbow joint, lateral epicondyle of the elbow that gets inflamed by too much repetition doing tennis or other repetitive motions of the forearm. And patients with inflammation of the lateral epicondyle of tennis elbow do not complain of pain there, although you can push on that joint and it hurts. They complain of pain in the forearm generated by muscles of the forearm, which pull on the bone of the forearm and create pain. The muscles don't create the pain literally. The muscles react to inflammation in the joint because the brain says to the muscles that move the joint, don't move the joint. That is the mechanism of tennis elbow, which has been well known by the orthopedic surgeons, by the physicians who treat tennis elbow for at least 50 years or more, because it was taught to me by one of my fellow residents at Vanderbilt in the very early 70s. So tennis elbow is nothing more than inflammation creating a signal to the brain. The brain says, I'm going to help you out. Don't move the joint. It's inflamed. Rest the joint. Rest the joint. Don't move the joint. Sends a signal back down through the neural system, sympathetic portion of the autonomic nervous system, to tighten up the muscles, tighten up the joint, tighten up the muscles, don't move it. And then the muscles actually pull on, when they tighten up, they pull on the bones. And when they pull on the bone of the forearm, the bones of the forearm long enough, they will stimulate the pain receptors. They're called nociceptors. And then a return signal goes back to the brain It hurts. And that is called tennis elbow. And as it works out, tennis elbow and TMD are the exact same disease, the exact same mechanism. That same mechanism, inflammation in this joint, sends a signal to the brain, lower levels of the brain, brainstem, where actually all the cranial nerves are. And it sends a signal to the brainstem in the area of cranial nerves. It's inflamed, and the autonomic nervous system then modulates it, sends a signal back down, don't move the jaw. And all the muscles that move the jaw, and there's more than one for sure, and the doctors out there know what they are, masticatory muscles. And wherever those muscles are inserted into the skull, into the jaws, into the face, the muscles of the bones of the face, wherever those muscles are inserted into the upper and lower jaw, into the side of the head, into the undersurface of the mandible, wherever those muscles are inserted, they pull on the bone, and where they're inserted in the bone, it creates pain. And now all of a sudden you have unusual, very unusual kinds of facial pain that move around, by the way, because the signals are not always sent to the same muscles. And historically, that was called TMJ, which is the name of the joint, temporomandibular joint. Similar, it's like going to the orthopedic surgeon with knee problems, and you walk in the room and he says, "How can I help you?" And he says, "I have knees." Everybody's got two knees and everybody's got two TMJs, but not everybody has a jaw joint problem. But that is the mechanism. And it took a surgeon who did 2,000 surgical cases to actually understand that the common denominator was inflammation. It was common denominator. And then it was a matter of understanding the other two components that brought the actual solution into view, which is the other two components were 90% of the loads on the temporomandibular joint and tennis elbow and TMD are the same disease. And when you understand those three concepts, it becomes obvious that the better way, the best way to treat TMD is to unload this joint just like you unload the lateral epicondyle of tennis elbow by placing the patient in a sling. Or similarly, if you don't want surgery or injections into your knee, the best way to make the pain of the knee go away is to get on a set of crutches. And it works both in tennis elbow in a sling and on the knee with crutches 100% of the time. If you have an inflamed knee and you go on crutches, the knee pain will go away in a few days because it takes a while for the inflammation to die down. If you have tennis elbow and inflammation of the lateral epicondyle, and you put the arm in a sling and you don't use it, within a few days, you'll start to get relief from pain in your forearm. And if you put your mandible in a device that unloads the temporomandibular joint with a protocol that has to work correctly, you have to use it correctly, you have to follow the protocol, which is 24/7 for 2 months, nighttime only, indefinitely. You unload the joint, this joint enough, and the inflammation dies down, and all the symptoms go away, because both in the knee and in the elbow and in the temporomandibular joint, all of those symptoms are driven by inflammation within the joint. Non-steroidal anti-inflammatories work really well in any joint. They work really well in this joint. The problem is they only work for a short period of time and they run out of steam. So literally, it took a surgeon who, right or wrong, persistent or not persistent, spent 36 years trying to help people solve their temporomandibular joint symptoms via surgery. But now, approaching 15 years ago, I felt that long-term surgery was not going to be the answer, and did the research, did the thought experiments, begin doing the work with patients themselves, and found that literally, if you unload the temporomandibular joint according to a protocol with a simple device that they can speak with, that they have to take out of their mouth to chew, but they can speak with and they can use over a period of time indefinitely, because once you start unloading the joint, it has to be continued. But the protocol, it works extremely well, 24/7 for 2 months, nighttime only the rest of your life. And if you do that, the results are the same as if you had a sling for your tennis elbow or you had a set of crutches for your knee. And that is why it took a surgeon to figure this out. And I think anyone with had the intention and had the experience of 2,000 cases and had an experience going to dental school and learning that 90% of the loads on the temporomandibular joint come from the posterior teeth, and the one that was really hiding and allowed me to understand where to look, how to go about doing the research, was when I realized that tennis elbow works the same way as inflammation within the temporomandibular joint. The dental schools teach that this joint is different. Every dental school. And I ask anybody to disagree with me, because no one so far has. Every doctor, dentist I've ever talked to has agreed that they are taught in dental school. This joint is different. It's not like any other joint in the body. It's totally different. It's complicated. It's so complicated we can't figure out what's going on with this TMJ problem. We can't figure out TMD. And we bring 6 or 8 different disciplines in to treat TMD, when actually it's extremely simple. You don't need 6 or 8 disciplines. You don't need drugs. You don't need botox. All you need to do is unload the joint adequately over a period of time, and the problem will dissipate as long as the patient is consistent with the protocol. But the dental schools teach this joint is different, and they weren't ever going to figure it out as long as you start out from the position that this joint is different, because you have to acknowledge that this joint operates like any other joint in the body. The mechanisms, the autonomic nervous system operates with this joint just like it works with the knee or the elbow. And it's the autonomic nervous system that sends out the signals derived or created by inflammation in the joint that says, don't move the joint, don't move the elbow, don't move the elbow joint, don't move the temporomandibular joint. And when those signals arrive at the muscles that move the joint, the muscles get the signal to tighten up. They tighten up and attempt to move the joint. When they tighten up, they pull on the bones that they're attached to, and that's where the nociceptors are, the pain receptors, and then pain is generated and goes back into the brain as a perception of pain, and it hurts. So that is why it took a surgeon. I'm mystified why it took 70 years to figure this out, because I'm not the only surgeon who certainly has tried to address temporomandibular joint problems. I am probably the first surgeon who tried to figure out a non-surgical solution. I don't know of any other surgeons who have tried to figure out a non-surgical solution. And if there are any out there, I'd love to talk to you. I truly would. So that's what I have to speak on today. I appreciate your attendance. I appreciate you being here. I really hope I've opened up some insight, whether you be a dentist, a physician, nurse practitioner, or especially for patients who suffer from these disparate, terrible symptoms. For those of you who'd like to communicate with me, I'm reachable at tony@tmjservices.net. Anyone who'd like to criticize, I'm open for criticism. Just make sure you bring your proof of what you'd like to say with you to criticize, what I have to say. Whatever your point of view is, I'd be happy to listen. Just bring your academic proof with you, showing that whatever you have to say is meaningful and not just a bunch of smoke and mirrors. Next week, we have a special guest. I am doing an interview with a patient who underwent some unusually inefficient way to treat temporomandibular joint using orthodontics. And this is a common problem in our profession that I've spoken on also, but I'm gonna do a interview with a patient, very nice patient, who is going to solidify and outline exactly what the problem is and what we had to go through to help her. So until next time, I'm Tony Urbanek. This is TMD Demystified.